Good afternoon and welcome. This is to the Joint Health Overview and Scrutiny Committee. I am Councillor Derek White. I'm the co-chair of this committee, along with Councillor Karen Calder from Shropshire Council. Now, due to the current COVID-19 regulations, today's meeting is held using audio conferencing and available to the public to listen to via an audio feed on the agenda page of our website or via the Council's YouTube channel. This ensures that all those involved or interested in the committee can hear the proceedings. Members and other participants should only speak when invited to do so by the co-chair by using the raised hands function. Likewise, will everyone ensure that their microphones are on mute while they are not addressing the committee. Although anyone disrupting the proceedings will have their microphone muted or be removed from the meeting. Should the meeting video or audio quality become poor, I will ask all in attendance to switch off all the cameras when not speaking. Please can I welcome in addition to the additional councillors and officers from both authorities we have joining us today, as well as representatives from external organisations. Any individual who are not part of the Joint HOSC Committee are asked to direct their questions and comments to the Joint HOSC chairs via the raise hands function, who in turn will decide whether to put this forward to the officers from the MFPT. Now, normally we'd read out the names of the people present, but I'd really like you to introduce yourself individually, who you are and who you represent and why you're here. Thank you. Can we start off? My name is Derek White. I come from Telford and Wrekin, and I'm the chair of the Scrutiny Committee.
Can you not make noise for 5 minutes? Enough.
Can you introduce yourself, Steve?
Yeah, I'm Councillor Steve Reynolds, Oaken Gates and Ketley Bank Ward in Telford.
Andy?
Yes, Andy Burford, Cabinet Member for Health and Social Care, sitting in on this meeting. I'm afraid I have to leave in less than an hour for another meeting. Thank you.
Dag?
I'm Dag Saunders, cooperative member from Telford and Wrekin.
Daniel?
Daniel Webb, Shropshire Council Overview and Scrutiny Officer present.
Elaine?
Hi, I'm Elaine. I'm the project manager for PODS Parent Care Reform and based in Telford.
Joseph?
Hello everyone, Democratic Services and Scrutiny Officer from Telford and Wrekin Council.
Heather?
I'm Heather Kidd, Shropshire Councillor for Cherbury and I'm also a school governor, so I know about some of the mental health issues.
Hilary?
Hello, I'm Hilary Knight. I'm co-opted member of Telford and Wrekin Scrutiny Committee.
Ian?
Ian Hume, co-opted member from Shropshire.
Janet?
Hi, my name's Janet O'Loughlin. I'm a co-opted member of Telford and Wrekin.
Jane?
Jane Stevens, Strategic Coordinator of PODS Parent Care Forum, representing families with disabled children.
Helen?
Hi, I'm Helen Jones. I'm the BU Quality and Governance Lead for the Emotional Health Services.
Julia?
Hi, I'm Julia Dean. I'm Service Manager for Special Educational Needs and Disabilities within Shropshire Council.
Karen?
Hello, I'm Cam Bradshaw. I'm the Director of Children's Services for Shropshire Council.
Anne?
Hi, I'm Dr. Anne McLaughlin, Consultant Clinical Psychologist and also Clinical and Care Director for Shropshire, Telford and Wrekin Care Group for Midlands Partnership Foundation Trust.
Madge?
Hello, I'm Councillor Matt Shinton for the Clibberry-Mortimer Division. I'm also a governor for the primary school.
Angela McClements.
Hi, I'm Councillor Angela McClements, a Telford and Wrekin councillor, and I'm chair of the Children and Young People Scrutiny Committee on Telford and Wrekin.
Kelly.
Hello, my name is Kelly Middleton. Man in Place is Health and Wellbeing Specialist, and I'm here representing the Third Sector Professionals Group.
Claire.
Hi, yeah, I'm Claire Parish. I'm the service manager for the BU service as well as the urgent care adult pathway in Shropshire, Telford and Wrekin as part of MPFT.
Peggy.
Hi, I'm Peggy Mullock and I chair Children's Scrutiny at Shropshire.
Kathy.
Hi, I'm Kathy Riley. I'm Managing Director of Shropshire, Telford and Wrekin Care Group, which is part of Midlands Partnership Trust.
Kieran. Sarah.
Hi, I'm Sarah Thomas. I'm the Participation Coordinator for the Shropshire Parent Carer Council, otherwise known as PAC, and a parent carer.
Sadia.
Hi, I'm Dr. Sadi Wahid, Consultant Child and Adult Psychiatrist, and I'm also Medical Lead for BU, Midlands Partnership Foundation Trust.
Stacey.
I'm Stacey Worthington. I'm the Senior Democratic and Scrutiny Services Officer from Telford and Wrekin.
Zara.
I'm Zara Bowden. I'm the chair of Shropshire Parent and Carer Council. I'm also the West Midlands Regional Representative for Parent Carer Forums across England and cover the 14 forums in the West Midlands, so have an understanding of MPFT and their wider relationships.
Right, that's everyone that's participating at the present moment. Can I remind you now to all mute your phones until requested to or asking a question. Thank you very much.
Chair, if I might, I'd just like to proffer apologies from Rachel Robinson, the Director of Public Health at Shropshire Council.
Yeah, and also that we've got Karen is at hospital, but she will probably try and join us as quickly as she can when she comes back from the hospital. Right, thank you very much indeed. But we've always had problems ever since I've been chair of scrutiny for many years that we've had problems with CAMS. It wasn't working. Sorry, Joe.
Sorry, Chair. Can we just go through the
through the agenda? Yeah.
Yeah. So we should probably.
All right. Apologies for absence, Joseph.
None received.
Right. Declarations of interest. Anybody interested? No. Minutes of the previous meeting.
These will be agreed at a later date, Chair.
All right. So. Thank you, Joseph. We can now go into the service.
Sorry, need to do that.
To receive a report from Kathy Riley and from Managing Director, Shropshire and Telford Wrekin Care Group, Midlands Partnership, NHS Foundation Trust on Children's Mental Health Services. She will be joined by Claire Parish, Sadia Wahid, Helena Jones, and Annie McLaughlin. Right. Ever since I've been chair, we've always had problems, and this regarding scrutiny is certainly regarding the CAMS. For many years, it was struggling. It was ineffective. It was having long waiting lists. And I think it was about 3 years ago, they actually decided to recommission. Now, when they did recommission, they came forward with a dream of this is what the service was going to be. Now, can you tell us, Kathy, what's happened to that dream? Where are we going? What are we doing? How are we doing it? And where you see the problems are?
Thank you, Derek. We prepared a presentation which we want to jointly present to answer some of those questions. Are you happy for us to do it in that way?
Not the presentation you sent us, Kathy. No, we will not. We can't allow you to use that presentation, I'm afraid, because we've sent it out to all members. It will be used for background information, but quite frankly, it doesn't really answer the questions that we really have been asking.
Okay. So should we look at the report instead? Would that help you?
Well, we could start with the report, yes.
Great, thank you.
Would you like to lead on?
Yeah, I will do. So obviously the BU service, which was commissioned, as you say, in 2017, is consisting of a partnership. So it's made up of the traditional CAMS, specialist mental health part of the service, and partners. And the partners are Helios, Cooth and Beam. So it's a emotional health and wellbeing service which provides care up to people up to the age of 25 years of age. New referrals are taken for people under 18, but existing patients will be supported up to 25 years old based on their choice. So if they want to leave earlier to go to adult services, they are completely enabled to do that. As I say, it's a partnership of providers delivering different parts of the service based on the Thrive framework. And within the report, and within the presentation, it describes that Thrive framework of self-support, advice, guidance and consultation, getting help and getting more help. So after the service was commissioned, this model has been developed. In 2017, the service came over to BU with an aspirational vision for it and about its development. In 2018, the intensive support team from NHS England and I came in and did a diagnostic for us and reported back to the system. And from that, an improvement plan for the system, not just for the BU service, was developed. And that covered aspects such as workforce, culture within the system, because one of the things they identified was that the culture was that there was a pill for every ill, was the way they described it, so that medication was being used predominantly as the solution, that there were significant gaps in service provision, which wouldn't normally just be solely due to provision of a CAMS-like service, but the blame was being directed towards the BU service. And there was a workforce plan attached to that improvement. They also, linked to that pill for every ill, suggested that there was too much medication being used as a solution. And one of the early things that we had to do was a medication review of the full caseload.
Is now joining.
Okay.
So one of the things we want to cover today is that improvement journey with you. And so if I can describe that in a little bit more detail, and I will ask number of members of the team to come in under different parts, please. So as I say, one of the early things we had to do, and we did that from October 2018, was do a full medication review of the caseload, checking for polypharmacy, to make sure that all the medication that was being used was appropriately being prescribed, and also there was appropriate physical health tests being done. And I just wondered if I could bring Sadia into the conversation so she can give a little bit more detail to you about that.
Sadia. Well, Sadia is joining us, Kathy. You're on mute if it's Sadia. Would it help, because I know we've probably thrown a spanner in the works by not accepting your presentation, would it help to go to questions as quickly as possible so we can actually target in the areas that we really need to zone in?
Yes, if that's helpful, we're happy to do that. But I know that Sadia was keen to sort of describe the change around the polypharmacy and some of the case studies with you, so that you could get a flavour of the sort of difference that's happened during our improvement journey.
Okay, Sadia.
Yes, sorry, I was just trying to, get the system working. So yeah, polypharmacy was something which we really focused on. All caseloads, they were reviewed, and all the children's which were particularly prescribed antipsychotic medications, they were reviewed. We made sure that these patients, they were on the antipsychotic medication with proper indication as per our NICE guidance, and there was proper physical health monitoring in place for all these patients. So physical health clinics were then set up, and we were making sure that these patients were monitored both in terms of physical health checks, bloods, ECG, whatever was required in terms of its monitoring. We also strongly discourage the long-term use of the antipsychotic medication because of the related side effects. And we managed to do that pretty successfully by offering alternative behavioral therapies in place of the antipsychotic medication, which was used as a sort of a magic pill, and most of the parents, they were relying heavily on it without realizing its long-term side effects. So safe prescribing was something which we really emphasized on. We also made sure that our patients who were on the long-term melatonin use, which is mainly used for sleep medication, they were reviewed. We made sure that rather than on the liquid preparation, they were on the tablet or the capsule preparation, because that was a cheaper option. We emphasized on the sleep hygiene, not just relying on the pill itself. We introduced some sleep hygiene groups within our service in order to psychoeducate the parents and really encourage the sleep hygiene, rather than just relying on the medication alone. At the moment, we have got 2 pharmacies, Rollins and Lloyd's Pharmacy, so families can collect the medication straight away rather than, be coming to the bases in order to minimize the risk of the COVID infection, especially during the pandemic. That what we have introduced, because we did not have the facility of the electronic prescribing within our system. Now, coming back to the polypharmacy, obviously there are a number of cases, and I can give you a number of examples, but I've just picked, I'll just talk about one of the case. When I had joined the service in 2019, this particular young person was 13 years of age with a diagnosis of ADHD and related anxiety. He was also presenting with behavioral problems. It was quite a complex case, with lots of comorbidities. He was on the risperidone medication, particularly for the behavioral issues. He was also on the Scrutiny, which was for the sleep, as well as atomoxetine, which is a non-stimulant medication for the ADHD. Now, after I had seen the family, I had psychoeducated them about the long-term side effects of the risperidone use. I had emphasized on the biopsychosocial sort of holistic approach, had offered behavioral support with our partner agency BEAM, and had slowly, gradually reduced and ultimately discontinued the use of risperidone. Instead of Scrutiny, because it was not effective, as you're aware, in the long run, Scrutiny, the body gets used to the medication, and then you reach a plateau where it is not effective anymore. So I had considered stopping the use of Scrutiny. Instead, I had considered a short trial of the promethazine medication, which is not just used as a sleeping aid, but also helps to take the edge of the anxiety away, because I was mindful that the young person is suffering with the anxiety as well. And because they were heavily relying on the risperidone medication, there should be something, alongside. Again, this was short-term trial, as I said, and it was discontinued once the sleep pattern concerns were addressed. Currently, he's just on a monotherapy, which is single medication for atomoxetine, and he's doing completely well.
Thank you very much for that today. Kathy, unfortunately, this report has not been circulated to our members. It's actually meant for next week's meeting. So unfortunately, we won't be able to continue down this line. I'd rather just move to the line of questioning that we'd suggest. And we need to start with probably, let's start from the very basics here. What services does CAM provide? What is the evidence for the service, and what is the profile of its need?
Okay, so the BU service provides low-level support. So it's from its partners, BEAM, the Children's Society, and COOT provides a texting service. It has part of the partnership is Helios, which provides online cognitive behavioural therapy. And then there's the specialist CAM service, which has an access point, which includes clinical triage, will signpost and provide support. It's an all-age access point, so it's made up of, as well as adult practitioners, it's made up of CAM specialist professionals as well. And then you go into the core part of the service, which is likened to a normal core service. When we took on the service, the workforce for the BU service and that part of the service was predominantly medical and nursing led, and that was to meet the demands that were there around prescribing, which Sardia's just touched on. That has greatly changed over the course of the last few years. So we've got speech and language therapists, we've got occupational therapists, we have a number of psychological practitioners, CBT therapists, specialist trauma therapists, all part now of the workforce. So that's one of the things that's linked into the improvements that have happened. So there are now a range of therapies as well as prescribing that are offered by the service. There are also specialist pathways as part of the BU offer. So there's a learning disabilities team. There are neurodevelopmental teams. So there is an ADHD clinic that is now formed. What there was always lack of clarity on as the tender came out was ASD diagnostic pathway, Derek. Yeah. So I'm really pleased to say that in August 2020, the CCG have now clearly commissioned that and have added to the funding that the services receives for us to be able to develop that ASD diagnostic pathway. Previously to this, we'd only had a waiting list initiative that had been funded for that element of the service, which was for people, children and young people who've been waiting longer than 12 months. So we're now in the process of recruiting to the ASD diagnostic service, and I'll hand over to Claire Parrish, the service manager, who can give you a bit more detail around that, because I know that one of the questions, Derek, was around neurodevelopmental in particular. And then after Claire's given a bit more detail around that, I'll come back to the evidence base and maybe hand over to Anne, our clinical care director, to give a bit more detail on that, if I may.
Go for it.
Thank you, Derek. Claire, would you want to give a little bit more detail around the neurodevelopmental pathway and developments, please?
Yeah, obviously neurodevelopmental, the success of a neurodevelopmental pathway is ensuring that as a system we're working together. As Kathy's alluded to, we have an ADHD pathway that did have a long waiting list, and as of yesterday there are only 29 young people waiting to be seen, and that was from over 100 young people. So we've dramatically reduced the waiting list for ADHD, and all children have virtually all now been seen and have started the pathway. In terms of ASD, it has had some complex issues, and I think it's just put into context that this isn't specific to Shropshire, Telford and Wrekin. This is a national picture throughout the whole of the country. We have recently had funding from the commissioners to set up a diagnostic ASD service. We have virtually recruited to all posts now. I think I've just got a Band 6 advert out at the moment, and a specialist language and speech and language therapist to recruit to. However, we've already started a trajectory looking at ASD. So we are currently, as of yesterday, actually I had the meeting yesterday around looking at those children that are waiting over 12 months and those new children, and actually having two separate teams of staff working to support those young people so that we can hopefully get in line with NICE guidelines. So we have put a heck of a lot of work and effort into developing and getting a specific ASD pathway set up, and that has now occurred. We did have the waiting list initiative, and we had 6 months to complete that, and we did that within the time frame. So yeah, things are moving forward. With ASD, it isn't an easy thing to diagnose. There are a lot of complexities that we have to look at and evidence to ensure that we are making the right diagnosis. But we do have the team now and are working at the waiting list and also the new patients that are coming through. I think what's really useful to add is that part of this we have introduced in Telford a real good link with the local authority and schools, where we have this educational health and wellbeing panel. So all young people at schools, any school has any concerns regarding a child's mental health or any neurodevelopmental, it goes to a school's panel. which is very much multidisciplinary led. So we are part of that panel, as our public health, as our local authority, as are the schools, as our early help offers. It's a very much a wide forum, and we look at the individual child and look at actually what has been put in place to support that young person and actually what is required. Sometimes that isn't BU, and there are other agencies or other disciplines out there that actually can provide more, but enables us to identify those young people that do need our help, and we're able to do that. We also have the mental health support teams now that have gone into schools, so they're able to work directly with the schools and identify early any young people that need some support in any way, shape or form. And we are looking to set up the same in Shropshire, and I know that's currently in transit and is being worked through at the moment.
Thank you.
What works in Telford certainly doesn't always work in the county. It's such a different area, and so its sparsity is one of the biggest.
I agree, but I think neurodevelopmental is neurodevelopmental across the country, and that's what we're focusing on. And I think it's looking at the child. That's what we're focusing on. That's what we've done a heck of There's been a lot of work actually on it.
Madge, you've indicated.
Thank you, Chair. Just really thank you for that information. Just 1 or 2 points that I could do with a little bit more information on. The level of staff that you have at the moment, skill levels, where your shortages. You say you've just finished recruiting. I'd be interested if that was a comprehensive recruitment or was it just in one section. The links with schools, sorry, I should have said I'm a Shropshire councillor, so I do understand that the difference between Telford, Wrekin and Shropshire, so just for that. The involvement of GPs, because a child is a part of a family, and I think the family GP needs to be kept up to speed. So I'd like to know what sort of information go to them and what involvement the parents have. I didn't hear you mention parents, and all these different agencies that you've told us about. Just who's joining the dots up?
Obviously, in terms of the GPs, for any child that we see, we document and we communicate through letters to the GP. We have a consultant that works part-time within our single point of access. So any referrals where a doctor is specifically asking around medication or asking for a medic's opinion before coming into the service, we now have a doctor that spends time in access and will answer those GP's questions. But any child that we see or work with, every letter is copied back to the GP, and so yeah, that communication remains. In terms of recruitment, we've done recruitment across the whole of the service, so I can't give you exact numbers of how many staff I've recruited into the BU service. I don't have that information to hand. But yeah, there has been a large recruitment process within to look at the skill mixes. So we have now, I think, got 4 OTs, etc. So yeah, I can't give you exact numbers of just how many staff I've recruited to for the whole of BU.
Madge, were you referring to the ASD diagnostic service when Claire mentioned that she was recruiting to that? Did you want to know how many posts were related to that part of the service?
For me, it isn't just ADHD or ASD, it's the whole of the service. And that's really the question I was asking, was the breadth and skill level. Perhaps I didn't make myself clear. I do apologise for that, because I'm not quite sure what skills are out there that you can actually recruit from.
Okay, so
I suspect that there is a shortage of certain levels of skill, and I was just wondering how Telford, Wrekin and Shropshire are doing in that aspect.
We have been quite fortunate in a lot of respects. We have occupational therapists that work within the team. We have social workers that work as mental health practitioners. We have obviously RMNs, and we also have learning disability nurses. And staff. We have clinical psychologists and counselling psychologists. We have a consultant psychologist who is also trained and leads on our complex care pathway in terms of complex trauma. In addition, we have family therapists, we have systemic family practitioners. Obviously, we have nurse non-medical prescribers. We have a variety of, I'm saying we have a huge array of different clinicians now that weren't there before.
Yeah, rather than you going through that, and Marge, we have to. I'm sorry, we have to limit our area what we can do in the 8 certain areas, and we
Derek,
can ask.
Can I jump in, please?
That's fine, Chair. I understand that.
We can always write written questions because we'll have a workshop later on. Yes, welcome, Karen. Yes, Karen.
Thank you for sort of being sort of interacting like this. Can I just? I came in around the poly pharmacy, and then also now into the latest bit about ASD diagnostic pathways. I'd just like to ask a question around what is now. You're saying it's an improved. You've now got the diagnostic pathway in place. So what is now the time wait for an assessment for ASD, ADHD? And I'd like to hear, I think, if it's possible, from some of the parents of this particular group. We're hearing from the providers. I'd like to hear from the parents as well.
Right, we have got a number of people who are indicating the questions first, though, Karen. We need to, need to try and go through that. Jane, Jane, then Angela, then Dag.
I think there were other people before me, Chair, but I'm happy to input here if that's okay.
It's the list I've got here, Jane.
Thank you, Cassie and Claire, for the update again. It sounds great, doesn't it? On paper, it sounds great on the presentation. All this work that we're doing, but I will just say that we've been asking for certainly for the last 3 years since we ran a workshop for that we brought families together about the state of the whole CAM service, particularly about the neurodevelopment and the ASD diagnostic pathways. We have not seen improvements. We've been to many meetings where we've been told, yes, we're dealing with this, we're doing this, we're sorting this, we're getting down this waiting list. And you're just telling me now that you're just putting stuff in place now to make it better from now. But you told us that 12 months ago and told us that 2 years ago. So I'm really, I am angry. I'm angry for the parents. I'm upset for the parents that we haven't got this, we're not moving this forward. And also the fact that, we might have a diagnostic process, but what's going to happen after that? What happens after diagnosis for these families who are just crying out for some support? It isn't this, we're talking about this, safe prescribing. We're talking about this Thrive framework of passing people from one service within the BU Thrive group. We're just passed, we've got families being just passed around like hot potatoes. Oh, well, we can't do that, we can't do that. We've put the emotional wellbeing panel in place now. That's just caused an even longer waiting list. And for families who haven't got a good relationship with schools for whatever reason, then they're not getting through to that panel. It only need more of that meeting, and it's
Jane, just to explain how we're going to be working, really, is yourself and the pods and everyone else who's here on there, is active. What we will do is have a workshop, whereas we can sit down, all the committee and yourselves, to actually discuss what's happening. You're going to listen to what they're saying, how they're presenting it and everything else, and then you tell us how. Because you're right, there is a difference between what is planned, what is anticipated, and what really happens in the ground now. And you're very much at the coal face, and we're going to value your opinions. So what we'll do is we'll actually try and have a workshop meeting between the joint HOSC and yourselves and other user groups to actually listen. And find out where the real problems arrive. At the present moment, we need to actually go through the area. We've got Angela McClements, Dag Saunders and Heather Kidd, and then Kelly.
Thank you, Chair. I think Marge and Jane are actually covered the questions I was going to ask, but I do see it as a sort of real priority, that sort of collaboration and communication with parents and schools. I'm hearing it so many times, with things that I pick up as a borough councillor, and I think it needs to be a sort of priority. Are we listening enough to the experiences of schools, in particular primary schools? And how does CAMS work, with the schools to identify the most need? There seems to be CAMS, it's saying it from the organisations, but when you come down to a lower level, and speaking to the people at the forefront of it, you're getting a different story. So I think that workshop is absolutely crucial, Derek.
Absolutely right. Yeah. All right, we've got Dag next.
Yep. Hi, Kathy. I've got a load of questions later on with crisis prevention, mental health support team, eating disorders, COVID-19 response. So maybe there'll be a time to cover those. But just a bit of background, first of all, there might be members of the public listening to and watching the meeting. So just to get an idea of the board position, is there uniformity in the commissioning of the two CCGs of your service, or are there differences in the way the service is commissioned between the two CCGs? And do you know if that's underpinned by the FTP?
So we have the same service spec from the two CCGs. I'm also aware that the local authorities put into the income that we receive, but not the detail and the split of that. So yes, there is uniformity from the two CCGs, and that has improved with the new tender, I believe. We have exactly the same service spec.
So the difference in school support is more on the ground than what's commissioned by the CCG then?
So if I can pick up the schools bit, is that there was waves of funding available, transformation funding available to fund school-based teams with counselling and training available. So we had to bid for that. So Claire bid for that. Are these
the mental health support teams talking about?
Yes, called Trailblazers. So
and you're one of the national trailblazers.
I can probably add to that. Yeah, we have two teams, one in Telford and one in Shropshire, who provide support to a variety of schools across primary schools and senior schools. In addition to that as well, we also are part of the Anna Freud Links programme, which is again across Telford and Shropshire. So there are regular links and meetings with schools.
Are you familiar with the BPS briefing paper on support teams? And if you are, how near are we to getting the structure to reaching the structure that the BPS has recommended? It's quite a complex structure, as I'm sure you know. So how far are we to getting the full structure sorted out? And how many trained education mental health practitioners do we have? I think the recommendation also says we need to have mental health practitioners from diverse backgrounds. So of the trained ones we have in post, how many of those are from diverse backgrounds, and are they focused on schools of high deprivation and areas of high deprivation, or is it just a blanket service? Is that clear? It's a bit muddled, I know.
Yeah, when the bid was put in, it had specific criteria about what schools we were targeting. So we worked with the local authority and schools to look at those schools that had the highest level of deprivation, also that had the highest number of referrals into the early years programmes within the local authority, and had the highest number of exclusions. We have a group of emotional health and wellbeing practitioners that are currently going through their training at the moment, and they qualify in December. It's a 12-month training programme. We also have band 5 practitioners and band 6 practitioners. So they are equal across both Telford and Shropshire. In terms of diversity, it's a full diverse background of various ethnic groups.
that work within those school teams. And again, it's across Telford and Shropshire.
Thank you.
If that answers your question.
We need to move. We need to move into the next question, and that's Heather.
Right. Okay. It's always difficult to actually unmute. Thank you. I'm really interested in how you design services to fit areas. I mean, Derek's point around Telford and Wrekin being quite different to Shropshire is a well-made one. And how do you hope to roll out these services in Shropshire where they don't exist? And who will you talk to make sure that you actually understand the rurality issues that we have? I was slightly disturbed by the references earlier to using Rawlings and Lloyd's pharmacies, because we don't have those in the rural Shropshire. So that's just an indication that actually the way you deliver a service in our area is going to be fundamentally different, and how you tweak the existing ones to fit both areas in their different ways. And how do you take that input forward to make sure existing services do replicate what we need, especially alongside COVID? Right. Good. Kathy, are you going to be able to answer that?
Yeah, it is, as lots of CAM services are, it is got a very defined resource. So one of the things we've done during COVID is that we've used a lot more of video consultation, which allows us to, with ease, get to different people in different communities. Now, that isn't fit for all. We've also continued with face-to-face, telephone support, our support from partners, which includes online. So that is part of the answer, but not the full answer by any means, Heather. I haven't got a definite. What we are working with as a system is population health needs, and we're waiting for some more information for us to understand how we need to look at our resources linked to particular PCN areas. And we're starting to work more with the primary care networks as they develop. And we know that particularly in Telford, there is one PCN that particularly wants to work with us around the 18 to 25 age group. And so we're starting to develop plans with them, and I'm sure that will progress further with the different primary care networks as we move and they develop.
Yeah, I think. Can I come back slightly? Yeah, you can. Yeah, yeah. In that, actually, when you're delivering services to our rural primary schools, they are quite isolated. So how are you going to work with them, because the PCNs don't quite fit with them? And working with our rural head teachers would be a very good thing. And we do have school development groups over here where you could actually work with the group rather than individuals.
That sounds great. If you can give us some more information around that, Heather, that would be really helpful for us, and we will try to do that. I know Claire wants to come in.
Yeah, we do have a lot of, as I mentioned, we are part of the Anna Freud Links project, and that sees schools from all over the county. So we have a meeting in North Shropshire for schools in North. We have one in South, one's in Church Stretton that we go to, and these are led primarily by the local authority and schools. Obviously, we are part of that membership group, so we do have contact with schools across the whole county, and obviously the mental health support teams are in schools in those rural areas. They're not just in Shrewsbury Centre.
Hold on, Heather. Yeah. I think what's coming very clear to me, this is very much a developing service. We've heard Claire very clearly saying that she's recruiting now, but we've had 2.5 years, 3 years where you must have been working very short-handed, or you've been working in a vacuum. Now maybe it's lack of cash or whatever it is, but it's clear it's a developing service, and you're far from fully fledged, up and running, full steam. And therefore, but what concerns me above all things is, while you're in the learning curve, and because of the problems we had before, there is many young people there who have had very little or no support at all. Now, I'm not going to go into that, but because Kelly Middleton, you're the next question here.
Thank you. when you're saying waiting lists have come down, that, as a parent, I'm going to talk as a parent, but this comes up a lot within my work as well. My daughter was referred by the GP for an ASD referral. After 8 months of hearing nothing, I called up and they said, oh, yeah, no, we signed her off. They'd basically taken her off the list because the number didn't work. When they read the number to me, it was my number. Nobody contacted me or sent me a letter. So I had to go back through the GP and do it again. My daughter was 13. She leaves school in the spring now. Then we got a letter after another referral saying that I needed to get a letter supporting from the school and that they wouldn't do anything. And there was no point diagnosing because it wouldn't be treated anyway. And I hear this a lot in my work. And because my daughter's well behaved, which is a good plan, isn't it? She doesn't get any help. She suffers herself, but doesn't act that out at school. So in terms of the supporting letter from the school, it wouldn't have validated the referral from a parent and a GP. So she's had no support at all and leaves school soon. So she's having to battle for herself with obviously my support. And I hear this a lot from really, really frustrated parents on the best thing to do. So I'm not surprised the list has gone down because nobody's been put on it. My daughter didn't even get a diagnosis, which is very evident that she's got ASD. And the doctor had no doubt she had ASD, but I mean, I think there's a big problem in even getting to that, even to that part of the service. You can't even get diagnosed or any support, and there's never been a follow-up since then. The school wouldn't let her do the things that were helpful because she hadn't got a diagnosis. So I had to go and have a meeting and ask them if she needs 5 minutes because she gets overwhelmed. She's also quite high sensory. So I just don't understand, unless there's a behavioural issue, and it's that thing in mental health, isn't it, about who it impacts upon, and if it's not on the community as a whole, then nothing happens. So just as a parent's view, that needs looking at, doesn't it? And I mean, it's probably too late for my daughter. I'll probably work on getting her into adult service if that's necessary, but she was 13 when I asked her. So, and that's a big problem, isn't it?
Thanks for that, Kelly. Yeah, it's a parent's view, but it's also someone who works very much at the core of the front line in dealing with adult mental health problems. Zara.
Thank you, Chair. In my role as a representative of the Shropshire Parent Carer Forum, I'm also in the fortunate position of being the regional representative of all 14 forums across the whole of the West Midlands. Now, CAMHS is a bit of a mess nationally. We recognise that because we have an escalation of need in the way of, we talk more about it in schools, educators and settings are more upskilled in understanding that behaviour is a demonstration of unmet need. It is not actually a problem in itself, which warrants further investigation, which usually instigates early help support or CAMHS referrals back in the day. And obviously we're changing that slightly in the Shropshire Telford and Wrekin footprint, where we have the BU interim service for those lower level support needs, and obviously CAMHS is there for the much higher level. I am so frustrated in hearing at the moment about how it is taking you 3 years to get to the point where you are actually feeling like you're in a position to recruit and feeling like you're in a position as an organisation to start making headway on what you were commissioned to deliver 3 years ago. And the frustration I'm feeling is because the question I have is, how are you utilising your strategic engagement pathways to challenge back and to support your teams better, but also support your wider community by using the intelligence that you're gathering as an organisation and the barriers that you're facing to do your commissioned role effectively, to challenge within your strategic framework of this is a problem. Now, we know that you have done so recently, and that has resulted in some more money coming your way to support the autism diagnostic pathway and resolve that small problem. But my question is, how confident are you that you are utilising your strategic opportunities with parent carers co-producing your service delivery moving forward, but also with you shaping the strategic footprint in Shropshire and Telford and Wrekin to ensure that your service is properly supported by the other services around you that enable you to do your job well?
Can I respond to that, Derek?
You certainly can.
Thank you. This service, the ASD Diagnostic Service, was not clearly commissioned or resourced from the start. That has been escalated through, and if you asked for the minutes of the Strategic Commissioning Board since we took on the service, the intensive support team from NHSEI was invited in to do their review, and they clearly stated in their report that there was a lack of resource and commissioning around that. It has taken until August 2020 for us to be funded, but that was not through lack of escalation. So we are recruiting into those posts now. The only thing that we've had in the interim is a waiting list initiative, which we were funded to do last year. So these stories are appalling, Kelly. I listened to it and I am appalled, and I can only apologise on behalf of the system for you. But it's not because we had that resource and we weren't doing anything with it, or we were using that resource anywhere else. I can tell you that with complete confidence, that this is an historic issue in our system that is now resolved, but it's resolved too late, isn't it, for lots of people. In terms of the parent support groups, that is the next stage in our development. We're working with an organisation called Roller Coaster to give us some support on that. And if I could just ask Helen Jones, who I know is on the call, to come in, because she's been leading that on us. I just want to say that, yes, we are on a development journey, but this is something we're really keen and excited about. I just want Helen to tell you a little bit more about that. Thank you.
Hi, yeah, we're working alongside our colleagues in Staffordshire as well, really, to develop some working groups. We know that there is certainly an interest from some of our ADHD parents that we can move forward. We're looking at developing webinars and training opportunities for parents and carers to be involved in, particularly within that cohort, really. And we've developed close links with parenting programmes in particular with Shropshire, that we could directly refer to, really, and develop those connections. We're also looking at service user involvement as well, so young people involvement in the development of our service. So with, Claire and Kathy have talked a lot about the development. And at the moment, we're looking at specific areas around, for example, transition. So we want young people to be involved, really, in developing feedback systems and their care plans for transition, and what sort of information that they need to move forward, really. We've also reviewed our surveys and for feedback generally from our therapeutic interventions, and also we've developed for our questionnaire surveys for transition as well. So we're sort of moving in that direction, but obviously we've got some way to go, really, to involve people more. We have our involvement team as well that we've been working with. So we are trying to sort of recruit involvement, really, across the board, and they can provide some training and
Helen, can I just respond to that with, I'm not entirely sure. Being a representative of parent carer forums, we are funded by the Department for Education and NHSE to support you strategically to engage with parent carer communities. I'm not confident that your service is engaging the forums, which is the legally recognised mechanism within the Code of Practice, as the most appropriate strategic mechanism to engage parent carer communities. I appreciate you need to reach target audience, and that's completely, you know, we get that, and we would support and empower and enable that, and we don't want to be the only community that you reach out to and work with. But parent carer forums are strategic delivery partners, nationally, regionally and locally, and I am failing to understand how it has got to this point before you want to start working with parents in service development. This should have happened when you were developing and starting to think about what the engagement pathways look like to begin with. And I'm a little frustrated because you've answered my question, but actually what you've done is made it more difficult for me to understand why we've not had these conversations sooner, and how we've got to this point where our communities are feeling like they don't have the involvement they should have in supporting you to deliver a better service. Because this isn't about the community wanting to tell you off at all. And, you know, we're frustrated, so you can hear that in my voice, you can hear that from the other parents on the call. But in reality, this is because we want to help you to help our communities better. We want to support you to do that. I'm the co-chair of the Regional Learning Disability and Autism Children and Young Persons Strategic Board, and the consistent issue I hear is the lack of co-production and engagement with parent carers in service development. I just want to reiterate, it's really important that you involve us earlier on, much earlier.
Thank you very much for that. We're not going to proceed. Look, it is now 1:30. We've had an hour into it. We've got an hour and a half meeting, and we are approximately just still dealing with the first of 3 areas. Now, I've allowed most of the questions to go ahead because they do involve part and parcel of the questions that we were going to ask either within this sector or at a later sector. But we really do need to do it. Can we ask all those? And Sarah Thomas, I'd like to. You have been waiting for some considerable time, so I'll allow you to ask a question.
Thank you, Chair. Zara's actually picked up a lot of what we were talking about, but there is a question that I want to ask around the approach to diagnosis. And Councillor Middleton sort of highlighted the concerns that we do have, that there seems to be a culture of anti-diagnosis in the MPFT, and certainly around the neurodevelopmental pathway. And we were wondering what is the approach to diagnosis? Why do we hear repeatedly from families and concerns about being told that they don't want to label their young people? And yet what we know, as Councillor Middleton said, that often access to services is dependent on the diagnosis being made appropriately, of course. We know that in Shropshire we have one of the highest exclusion rates in schools, which was picked up by the SEND inspection. And they also picked up the fact that we have a below national rate of autism. Now, we don't believe that is because we're doing something amazing in Shropshire that means we don't have as many autistic young people in the area as other people do. But what we do know is that we've had a failing diagnosis service for an excessive period of time. And that is leading to significant issues in our schools. If a young person is not diagnosed, they cannot benefit from the Equality Act. They cannot access the legal protections that are given to them through a diagnosis. And yet in discussions with the service, we're repeatedly told that they do not want to take, and in fact a statement was made recently when producing the written statement of action was about moving away from a diagnostic model, and we just don't understand your reasoning for that.
If I can just quickly answer, obviously we are bound by NICE guidelines, so any diagnosis we make, we have to follow NICE guidelines for that. And I think Kathy has obviously just explained the funding that we've only just had through August 20 regarding the ASD. So that may answer some of the questions. But everything we do is around, we follow NICE guidelines for diagnosis of all mental illnesses or neurodevelopmental or learning disabilities. That's what we're bound by.
Well, I would like to see your criteria for a referral, then in which case, because that's not clearly articulated anywhere and it makes it very difficult for anybody to challenge. So I'd like to see a very clear referral for autism diagnosis so that we could be reassured about that.
Thank you very much, Sarah. Like, can I ask all those who have put their hands up to actually put their hands down, with the exception of those that I haven't asked any, I haven't done. Kelly, Joe, you want to talk?
Chair, it was not a question per se, just more of a reminder to our colleagues from external organisations to direct their questions to you more so.
Joe, it takes time, and I'll decide if they're thinking. I'll just intervene if it's. I'll say we'll answer that in the different areas. So at the present moment, it'll just take up more time, and we've got half an hour, mates. We just need to move on. Push on, pal. All right, right. So where we're at is tell us what the demand for the service is, Kathy. You're on mute.
From a provider perspective, what we're commissioned to is to against our CYP access rates. So I can talk to you in that way. The CCG, I'm sure we were attending next week, will be able to give you much more of the demographic information and about the predicted demands and things.
That's fine, Kathy. So if they're gonna do it next week, there's not a problem doing it, because we really need to move on at a pace, if we don't mind.
I just wanted to make it clear that we're above our access targets that are set by the CCG. So our access target is in the mid-30s. We're in the mid-40s in terms of access.
Kathy, our CCGs are probably some of the lowest finances for mental health in the country. So if they are providing very low finances, I presume their targets are not that bloody excessive. And anything would be an improvement into what we've been having. So basically, I mean, that is some of the areas that we need to be tackling with the CCG about the funding, how you're being funded, why we've had this delay in funding, why we've had this. You can't build, a castle on thin air. And that's what you've been trying to do. That's why it's clearly, to me, it's what's happening here, that we've given this, they've won this contract. And when we had the discussion with the people who won the contract, he actually turned around and said, well, we didn't realize the complexities. Good God, why do you bid for things if they don't understand the complexities of it? And then it was into it, and then the finances are not there to actually do it. You can't be the lowest bidder and expect a gold-plated service. So we do understand, Kathy. This is not a blame game. This is, look, how do we actually get back to where we should be? How do we actually make sure the service gets the finances it needs, the support it needs, and also how do you actually engage with the people that need to be engaged with? And that's why we've got the groups we've got here. And that's why we'll be having a workshop with people, organizations, and saying, look, this is a better way. This is some of the people. How do we actually make sure that you get that contact? But I'm now wasting time.
I'd just like to give some assurance on that, Derek, because I do accept the fact that we haven't engaged sufficiently. But I think what you've heard is the degree of firefighting that we have done over the last few years. And there are improvements in the service that are visible. I think the ASD bit is the bit that is still got to be drastically improved, and we are aware of that. But now that we've got the funding, we can start to do it. But in terms of engagement with parents, that was definitely on our agenda before this. It's even more so listening to people's comments around that. That is something that I can give guarantee that we will take forward now.
But Kathy, it's nice that you actually turned around and said very clearly, because that's why we wouldn't accept the presentation. We don't want a glowing picture. We want to know exactly what the real problems are and how we can help. And because that's what we can't make it happen. We can suggest, we can make sure the right people listen.
Thank you.
Okay. So let's go on to the next one. Has anyone else got any questions in that area first? On meeting demand for service? Who's it? You got Doug first. Let's have Doug first, and then we got. Are you still got your hands up, Joe? Are you? No. Okay, Doug. And
Right.
who was that voice? Sorry, who's the voice that was here?
I think it was Karen, Chair. I think it was your co-chair.
Sorry, Karen. I couldn't. Sorry, Karen.
It's a very, very difficult way to take.
I do apologise, love. Yeah.
No, that's okay. Just going back to something that Sarah Thomas requested, and that was a clear criteria for a diagnostic referral. Is that something we should be pursuing as a committee?
I think there's a real problems within the diagnosis, and it's certainly one of the areas that, you know, trying to get a but then they turn, then the professionals turn around and say, but we don't like to put labels on people. But if you don't have a proper diagnosis, it's not labeling people, because you can't then give the proper help and support and the names. You have to sort of put some sort of label or name in order to be able to help a proper diagnosis. And I know it's always been traditionally a very poor area, isn't it, Kathy?
I think it refers back to, I'm sorry, I didn't get the lady's name. There was a speaker very early on when I came in.
Yeah.
She was asking the so what question. Okay, we got the diagnosis, we had the referral, we got the diagnosis. But then
that was Sarah,
what
isn't it?
Happens then?
Yeah.
Can I answer that, Derek, around the diagnosis, particularly around ASD? My understanding is the CCG are working with local authorities around the commissioning of a post-diagnostic service, but that isn't going to be through our provision. It's going to be with other providers. So you may want to talk to them more about that and explore that a bit more next week.
Now we can go back to Doug.
Thank you.
Yes, thanks, Doug. I just wanted to ask further on the question that you asked. How does the level of funding that the CCG Shropshire, Telford and Wrekin apply to the CAM service? How does that compare to other areas that the Commission services from you and the national figure? Are we below the national level, around about the same, or are we above the national level in terms of the funding for CAM services?
So the IST report did a bit of benchmarking around our workforce compared to that nationally, and that was back in, if you remember, 2018, but it showed that our benchmarking was lower than other areas, and that was comparing with CAM services, whereas obviously the commissioning of this service is slightly different because it goes up to the age of 25 for people within service, so we are definitely benchmarked lower.
Okay. Right, tell us, what is the demand for the service, Kathy?
So the demand for this, so we meet the demands for the service. It has got, as I said, it's the CCG are going to give you the demographics around that and the figures next week.
Sorry, I do apologise, I already asked that question. All right, so tell us, you know, what the typical waiting time is for an assessment?
So we don't have a waiting time for our the main BU part of the service. We don't have a waiting list. The bit where we have the waiting list is the neurodevelopmental, which is where you've heard people expressing concern. In ADHD, we inherited a large waiting list, and as Claire said, that is greatly reduced now. We only have 20 odd children and young people on a waiting list, and we're hoping to have no waiting list within the next few months, because we are addressing that. We've got an ADHD clinic set up, which has really helped in terms of our flow through of children and young people through ADHD and the support that they need. ASD is where we've got the considerable waiting list, and we're just working through, now that we've got the funding, to look at the trajectory as to when we could get down to an 18-week wait, and also when we can meet the NICE guidance target, which is 3 months. So we're working through that at the moment. With the funding, what we're going to try to do is, for new referrals that are coming through, we're going to try and meet that NICE guidance. But for those people who've been waiting, we're then going to do a waiting list initiative based on the waiting list. So we can start to give NICE guidance, evidence-based treatment for new referrals, and work through the waiting list at the same time. So we're trying to balance that, is our approach that we're going to take.
Sarah, what's your opinions? Sarah?
Chair, if I may, I want to understand, Sarah's point was raised earlier around the referral criteria, because actually where you're saying that you have a minimum number waiting list and you aim to have 0 waiting list, that's really easy to achieve when you don't accept that young people actually need help. We have many families who say that, and you know, we've heard previously from Jane and Kelly both about experiences where young people are not being accepted into either the BU service or any ASD or ADHD referral pathway, simply because then just being batted out of the referral system. And again, I speak from first-hand experience, where we have, you know, young people who can't access your service through any other route than the school referral system, which we know is flawed, because many of our young children who have mental health related needs that spiral from their autism or their non-diagnosed autism-related conditions, particularly, don't always present in school settings. They usually present in the home setting. And as you've alluded to, you know, this is much bigger than MPFT. This is about the pre and post diagnostic support. But in reality, if those young people's needs aren't being recognised as somebody needs to see you to understand what those needs actually are and if this is the right environment for us to address those, then it is really easy to get a 0 level waiting list. And Chair, I would like to request that they provide us with the criteria for their referral so that we can understand and unpick whether or not that is still fit for purpose in the current climate.
Zara, I understand your request, but what we'll do is, as I've explained before, is we're going to have a workshop where you, Sarah, and everyone else who is really involved in it, and then what we'll do is we'll look at what we've listened to, what we heard about, and then ask the questions. Because I can't, you know, we're now at 1:45 and we're not going to be able to go through the complete the questions that we've asked, and so therefore we'll try and rearrange a meeting, if it's all right with you, and Kathy, with yourself and your team. And what we'll do is then finish off the agenda. But we will have a meeting of the users as a working workshop environment where we can talk frankly, clearly, and then we can say, right, what is it we're looking for? What do we need? How we do it? And then we'll present that at the next the follow-on meeting, if that's acceptable to you.
Absolutely. Yeah? Thank you, Chair. That's very appreciated.
Not a problem. So have we got any more questions? I did see somebody's hand up there just now. That's gone. All right. So
no, it was mine, Chair.
It was yours, Angela. I was looking for somebody.
Yeah,
I thought,
just really, I think you've answered it, but it's Zara raises an important point. You know, for someone like me, you know, just seeing that criteria for referral. I know we're looking at workshops, but I think that is an action point, you know, that we need to take away. We need to have that information. So I would like that information from this meeting, if that's possible.
Yeah. And I think as I said, we'll have that meet. We'll organise that. But we also need to talk to the schools as well, as we've, you know, as they've been mentioned, and how they're actually engaging. Perhaps from that we can actually get a much better base for them to base their service on, rather than actually scratching on. You know, as I said, it's an emerging service, and the more we can do to actually make it emerge as a butterfly rather than anything else, then we need to do that. Okay, so we've got a quarter an hour. Is there anyone not had any questions or things that they've been requesting? Any answers? Right, we've talked about the neurodevelopment service, haven't you, Kathy?
Yeah.
And telling us what the typical waiting time for neurodevelopment service following diagnosis for ASD, ADHD, and what is the waiting time? Is there a waiting time?
So we've got some on ADHD. There's 20. Can you just remind me the numbers? Is it 23 or 26, something like that?
29 people on the waiting list for ADHD. In terms of recent referrals for ASD, we've just had in the last 6 months 120 referrals for ASD that have gone onto the ASD waiting list for assessment. So we are accepting high high numbers of referrals currently. Obviously, we have a longer wait for ASD, but as Kathy's alluded to, we've now had the funding to be able to address that.
Right. Look, Kathy, we've got, we're not here as your enemy. We're here as a critical friend. We're here to help if we can. Tell us, where's the gaps in the market? Where is it? Where are you really struggling?
In terms of the we struggle. Yeah, in terms of recruitment and vacancies, what we struggle for is substantive consultants. CAMS consultants, in terms of the national development of them, very few would come off the sort of development line every year. So it can be really difficult to struggle. We have been really lucky, Sadia is here today as a substantive consultant with the consultants that we've got, but that can be a difficulty for us. So at the moment we have 2 or 3, is it Claire, locum doctors within the BU service. There's at least 3, there may be more.
We've got two currently. Yeah.
2. So that is an area that we struggle with. Also, speech and language therapists, dietitians can be difficult to recruit into the service. That again is because they're very specialist roles, and people who are working in a CAMS service, so it can be difficult to attract them, particularly in a rural area like Shropshire. So they are the sort of roles that we struggle for, Derek.
Doug, you put your hand. Yeah, Doug.
Yeah, thanks. Can we move on to the if you
performance management,
higher level of things, the crisis. A lot of national focus clearly on young people self-harming, suicide threats, etc. So there is now a national focus on crisis provision, and I know that people at the centre love to have these targets, don't they? I think the current target is 35%, is it, meeting crisis provision? So I'm fascinated by that. I'm not really sure how you know what percentage of crisis need you're meeting, but can you just maybe talk about crisis provision locally and how you're coping with it, and how you're going to particularly assess whether you're at 35% and what happened to 65% you're not at?
So what we've got commissioned currently is a 9 to 5 Monday to Friday crisis service. What happened during COVID was there was a national requirement to create an urgent mental health telephone line, all age. That meant that if we had somebody urgently who needed a crisis response, we could do that for adults, but we couldn't do it for children and young people. So we, at risk, have moved to develop a children and young people's crisis service that will operate 7 days a week, 24 hours a day, and that will happen from the end of January. The CCG have now told us that they are going to fund that for us. We moved at risk, and that was because although nobody absolutely knows what's going to happen because of the COVID pandemic, all the experts were saying that we were likely to see a higher level of acuity and higher demands from children and young people. The other issue that we have is that is the lack of Tier 4 beds. So when children have a mental health Act assessment and they need a specialist children placement, we are not a provider of Tier 4 beds. There are only a small number of specialist providers, and lots of them are private providers in the West Midlands and nationally. So at the moment, when that happens, we've got children and people who are stuck waiting for Tier 4 beds. And that can mean that either if they're under 16, they're on Ward 19 in Princess Royal Hospital with our BU service coming in to give support, or if they're older than that, they can sometimes, as a serious incident, be admitted to our adult mental health wards. Or if we really feel like that was just totally unsafe, what we do is we convert our health-based place of safety temporarily into a ward to hold those people and try to care for them. So this is a big issue for us. So even with the Children and Young People Crisis Service, we still haven't got the the alternative to health-based place of safety for teenagers. And that's something that's been a task and finish group developed during COVID to look at. And there's been really good engagement from the local authorities, from SAF, ourselves. I'm going to forget everybody, but it's been really good multi-age, the police, multi-agency engagement on that. And we have got some winter funding to set up through Beam in Wellington, a sort of drop-in that will run Thursday through to Sunday in the evening up to 10 o'clock, which would give an alternative. We will also then have the Children and People Crisis Service, and one of their purposes will be to try to reduce the number of Mental Health Act assessments and scale things down. So both of those things we hope will help, and we need to evaluate that during the coming months. But yes, these are real issues for us that you touch on. And what we're seeing at the moment, particularly at half term, we saw it, and we did see a spike in July. We saw a spike in these teenagers with very high complexity and high acuity who needed tier 4 alternatives, and we didn't have the availability nationally. And so we got the sort of circumstances that I just described. And that again happened at half term.
And do a significant proportion of these young people tend to be people who haven't been known to service previously?
There's it's a mixture there. We're also seeing a spike in eating disorder patients who need tier 4.
And my next question,
yeah, and some of those are not coming forward early enough. That's a real issue for us. And so when they are coming forward, when they've referred into the service, we've got a small eating disorders team, children's eating, but they've got really good response times for urgent and routine referrals. So that's not the issue, but the issue is that they're coming forward too late. And so we're then immediately having to look for a tier 4 bed, and there's a national shortage of them. They are some of the real issues for us.
Kathy, you identified the real shortages in the areas that you've got the gaps. So tell us, what are the CCG and the MPFT doing about it?
So I took a paper on behalf of the Task and Finish group that I just described to Gold in the system last Friday, and sort of explained to the CCG that with the lack of the tier 4 beds, the CCG has still got a responsibility under Section 140 of the Mental Health Act to give alternative bed provision, and they are now starting to try to scope that and source what sort of beds. It's not an easy solution for them. I mean, these are really specialist beds with specialist workforce that would be required for them. It's not a case of just finding a room somewhere. So it's not an easy problem that the system is going to have to try and address. And also, they're very expensive, and we already pay for the tier 4 beds, but we're not getting our fair share of them.
Well, we're paying for them. We don't have enough. Surely, and we are exporting most of the children out of area to areas where they've got no help, no support, no family, who have to make real difficult adjustments. So why can't we have a local solution?
Yeah, and the tier 4 beds are not commissioned by the CCG, is the other point I just need to make. It's specialised commissioning that do it. So the CCG have got to try to influence that, but also they still have a responsibility to give alternatives to those beds where we can't get hold of them.
So who are in charge of the special commissioning?
So that's NHSEI.
NHSEI.
Yeah.
Right, thank you. Right. It's now 4 minutes to 2. I don't think we can go any further today. Can I thank everybody who's attended? Can I ask all the members of the HOSC to stay online? And can I say thank you again? Kathy, we'll need to revisit you, unfortunately. And I hope the team don't mind coming back and talking to us, and then we can finish off where we are. And as I say, we'll also be meeting with the CCG, and we're also going to be talking to a workshop of providers, of people in the front line, and we'll be able to feedback that. And as I said, I've tried to make sure that everybody who's been here has been able to ask the questions they've asked, and they'll also let at the end of the day, it's not satisfied some people, but it may be the basis of actually understanding for the future. Yes, Joseph.
Chair, I was just going to verify whether we were bringing this meeting to a conclusion, or if you were going to move on to the move on to the next agenda item. I was just hoping to confirm that with.
Well, the meeting was due from 1:30 to from 12:30 till 2 o'clock is the agenda meeting, and I'm not going to go any further with the agenda. I'm going to suspend the rest of the agenda.
Chair, it was just to figure out whether we needed to stop the stream or not. That was all. But thank you.
Well, no, I don't want to stop the stream because I want to talk to the HOSC.
Okay. Thank you very much, Chair.
At the end of every meeting, Joseph, I want at least 5-10 minutes for us to be able to talk to the HOSC about the next steps. Okay. And I've got a hand up, and is that you, Joe?
No, yeah. That's Anthea.
Okay. So thank you very much to all our guests, and can I ask you now to leave the meeting? Thank you very much indeed.
Thank you.
Bye.
Chair, it's Anthea.
Yes.
Just to clarify, when Joe was asking about ending the streaming, you want the public stream to end now?
Yes.
Yes. Thank you.
Sorry about that. Yeah.